Good morning, everyone. We can get started. This will be the second week I'll be doing the pancreatic lecture. I hope that y'all learned something for the cystic lesion of the pancreas. We're going to learn about the pancreatic neuroendocrine tumors, also referred to as PNETs, or peanuts, okay? Not the ones that you eat, peanuts. You're going to present with patients most of the time, again, with incidentally found lesion of the pancreas, such as this. Okay? Sometimes they will come in with symptoms. Sometimes you get referred, or at least if you specialize in this, you get referred by endocrinologists who have already worked up the patient. Okay? So, can anyone tell me what this lesion is? Small lesion, 3 centimeter. There's no way for me to tell. It could be a cystic lesion, it could be an adenoma, it could be a malignant lesion, it could be a neuroendocrine tumor, or it could be nothing. There's no way to know what it is. Okay? Complete history and physical exam, soliciting symptoms. Unfortunately, sometimes these symptoms are very vague. They're not specific. Same lesion. Here's another lesion. Can anyone tell me what this is? No. What about this? Right. Excellent. You guys are paying attention. But look at that. Look at it. Rinky-dink little thing. Turns out to be insulinoma. Once we did a laparoscopic distal pancreatectomy on this lady, all symptoms cured. She's not on any kind of medication. What about this? That looks pretty malignant, huh? Right? It's a neuroendocrine tumor. There it is right there. Non-functioning. So, it's going to be a very brief lecture. The reason why is because I don't believe in spending too much time on an esoteric topic, especially if you're not going to specialize in it, or especially if you're lucky if you have one, at max, 2 questions on it. Okay? So that's the reason why we're not going to spend a whole, a great deal of time on an entity that's quite rare. But you do need to know about it, okay? In general, people will say if they're symptomatic, you need to resect them, irrespective of their sizes. But like I told you, symptoms can be very vague, not very specific. Rarely are you going to have a patient with diagnosis of insulinoma. Maybe you lucked out to see a patient with glucagonoma with wasting, muscle wasting, and a pathognomonic skin lesion. But those are very rare. Most of the patients have what we call non-functioning neuroendocrine tumor. In other words, incidentally found. I cut them out. Pathologist says, Dr. Chu is a neuroendocrine tumor. The diagnosis is made after the fact. Okay? Management. You enucleate them. If they're insulinoma, everything else is resection. Okay? Keep that in mind. Insulinoma, you could resect or you could enucleate. All the other stuff, resection. Okay? If they're small, benign, like any clinical scenario, cases, if they're small lesions, patients are too many comorbidities, have too many comorbidities, those are the patients that you can watch. Okay, the peanuts are associated with MEN1. Here they are, MEN1, 3 Ps, right? This you have to know. Okay. For pancreas, for MEN, insulinoma, gastronoma are the 2 most common. Okay. For non-functioning tumors again, like I said, if it's functional, remove them regardless. Remember that rinky-dink little lesion I showed you? It's insulinoma. We remove it. Patient was cured. Okay? If it's less than 5 millimeter, asymptomatic can be observed. Between 5 and 2 centimeter, that's the gray zone. That's what needs to be done. Now, generally, if it's greater than 2 centimeter, generally resect. Okay? Read through this slide. More likely to be benign if it is less than 2 centimeter. Small, low number of mitosis per 10 high power field, and the Ki-67 index. Remember the Ki-67 index. That's applicable to neuroendocrine tumors. Okay? When they ask you which ones are predictive, prognosticator of malignancy for neuroendocrine tumor is Ki-67. Okay? Not adenocarcinoma, not squamous, but neuroendocrine tumors. Ki-67. I should have highlighted this red. Okay? So this is the algorithm. You know, the day before you're in service, look at the slides, commit it to memory. 2 centimeters cut off for neuroendocrine tumor. Okay? This one, again, the slide is basically talking about how to approach a patient if they're symptomatic and or they're big, that it's unresectable. You can use medication. Streptozotocin, that's a medication you should remember, commit to memory. Also, the later medications, right here. You need to know. They might ask you, okay? Quickly, for the different entities, insulinomas, we call the Whippush triad, right? Symptoms of hyperglycemia, you look at their insulin, you look at the glucose level, it's low, and then they're relieved by giving them glucose. They're insulinomas. Clinically, but you have to do diagnostic tests to confirm it. Gastronoma, the gastronoma triangle. You got to remember this, right? Got to remember, how do you test it? How do you confirm gastronomas? Positive secretin test. I don't think we do that test any longer because it could solicit such a dramatic symptom in these patients that a lot of places no longer do them. But they still ask you. Diagnostic test for gastronoma is a positive secretin test. Okay, medical students, if you take a test, if you have this question, come up to me and tell me. Otherwise, it's a very relevant question. I'm not going to talk about it. I do know for the residents that they often will ask this question. Am I right? Listen, right? Okay. Got to remember the zebras, Zollinger-Ellison syndrome, okay? Associated with that.
On that subject,
yep.
Stimulation test, I guess that positive secretin stimulation test, what that means, this was always confusing to me until this year, actually.
Okay.
Normally, correct me if I'm wrong, secretin is given, and someone who doesn't have a gastronoma, it'll decrease.
Decrease the glucose,
so
right.
In this case,
gastro, right. Right, in this case, it jacked it up. Okay?
That's practice questions where they give
right.
that, and they specifically say
right.
what happens. They don't say if it's positive or not.
Right, clarification. Normally, if you have secretin, okay, secretin will downregulate gastrin, except in this situation. Okay. Yes?
Sure. Dr. Chu, this is a oral board scenario with gastronoma and ZES. It's like they're asked on the oral boards.
Okay.
For the chiefs, graduating chiefs.
So, commit this to memory, okay? You got to know insulinomas. You got to know gastronoma. A couple more entities that you have to kind of know. Glucagonoma, yes, remember, has this typical pathognomonic skin lesion called the necrolytic microtoroid erythema. Okay? They're going to show you, they might show you a picture of a CT of a mass in the tail of the pancreas. Then they show you a picture of a skin lesion. Okay, you don't even need to read anything else. 37-year-old lady came in with, wasting and diarrhea, Okay? Lesion in pancreas, skin lesion, glucagonoma. Okay? Vipiomas generally occur in the tail. How do I remember that? V is almost in the tail end of the alphabet. Okay? They generally occur in the body and tail. And remember the WDHA, water, diarrhea, dehydration, achalaria, body and tail. Okay? You might need to know this, if not anything. It's just people who like to write these esoteric questions just to separate those who read and those who don't. Sunitinib is a tyrosine kinase inhibitor. It targets the protein-derived growth factor receptors and the VEGF signaling. Okay. Everolimus, which is an mTOR inhibitor. mTOR is mammalian target of rapamycin. Okay. We actually have faculty here, some faculty here, who have done a lot of work on mTOR. Okay. This is it. This table encapsulates the whole thing about neuroendocrine tumors of the pancreas. Okay? So I will set this PowerPoint to Gail, who will send it out to all of you. All you have to do is, if you don't have time, look through this.
The whole in-service exam.
In service, right? Okay? You can see the location, insulinoma, a third. Okay? Gastronoma triangle. Eupiomas, I already told you, the last letter of the alphabet, body and tail. Glucagonoma, similarly, body and tail. Somatostatin. Okay? Localization study, pretty much the same. Ultrasounds, the whole slew of them, CT, MRI, etc., etc. All right, malignant potential. They're basically 50% or more except insulin. You have to guess. What's the malignant potential of gastronoma? 50%? Good.
Is that why you only do enucleation for insulin?
Yeah, right. Because it's very low. Right? What's the malignancy rate of vipiomas? Take a gander, yeah. Don't look at it, just take a gander.
50%.
Yeah! 50 to 80%, good. Say 50% or higher, right? What's the chance of somatostatin being malignant over there? Don't look at it, just tell me.
50% or higher.
50% or higher, right. 65%, okay, good, right. See, simple, right? What about insulinoma? What's the likelihood of malignancy? Anyone? 10%, 90% is benign. That's why we can enucleate. Okay, these are the clinical symptoms that you can expect, how you diagnose them. Here it is, gastronoma, secretin stimulation test. You give them secretin, yanks up the gastrin level. Okay? Of course, you can diagnose glucagonoma by having high level of glucagon, right? Same thing, high level somatostatin, right? Pretty simple, right? How do you diagnose glucagonoma? High level glucagon. Somatostatin, high level somatostatin. Right? The one that I concentrate on is what? Gastronoma. It's a positive secretin test. Why is that? Because gastrin can be high in so many different clinical scenarios, right? You take H2 blockers, your gastrin level gets jacked up. So there has to be a way to figure out, well, why do you have high gastrin? But we don't go around floating around having high somatostatin level, right? So that's why if you get a high somatostatin level, you got somatostatinoma. But gastrin, well, you can have so many reasons to have high gastrin level, so we got to get another discriminatory test, the secretin test. Does that make sense? All right? Vipiomas, we don't have, this VIP floating around. We don't all walk around with watery diarrhea, right? Unless you have issues. But other than that, that's how you diagnose it, high VIP. Any questions? Now, somatostatin, they might give you a scenario, gallbladder, okay? Having all sorts of symptoms of GI symptoms, indigestion, whatnot. When you hear has cholelithiasis, diarrhea, GI symptoms, and a mass in the body and tail of the pancreas. Diagnosis is what? Somatostatinoma. Okay. Any questions? That's it. Any questions? I don't believe to drag this out, make it painful. These are the essential things that you need to know. Okay?